I'm Haddas from University of Rochester Medical Center.
I'm Aidlen. I'm the Chief of Spine Surgery at Newton Wellesley Hospital in Newton, Massachusetts.
I'm Tobias Mattei. I'm Assistant Professor of Neurosurgery and Chief of Spine Surgery at St. Louis University.
Oh, thank you. So thank you for coming today, guys. So I would like to speak about how we assess disability and function in our patients. So Mattei, let's start with you. Can you tell us more how you assess disability and function with your patients?
Sure. So I think we'll later discuss about the importance of patient-reported outcome measures and all of that. But I would start with the basics. I mean, when we're evaluating disability, the first thing is your clinical history, right? So either preoperative or postoperatively, you should conduct a comprehensive inquiry into the patient lifestyle, what they've been doing, how the problem that they are presenting, either the pain or neurological deficit is affecting their lives. What are they able to do? What are the limitations? And the second important part is the neurological examination. So I would say that even though we can incorporate some of the problems initially as a questionnaire before and after, we can compare all outcomes. I think from the clinical standpoint, there's nothing better than going back to the basics. It's comprehensive history taking and a detailed and well-documented neurological examination.
Yeah, and you're right. Surveys are easy to provide for patients, extremely validate, and really cheap to do. What about you, Jess?
Yeah, I totally agree. I think that the history is so important just to see, kind of where the patient started and how they've evolved in their functional decline, whether it be rapidly or slowly, what their neurological deficits are. And, like I'm sure Tobias does too, with teaching, residents and fellows and medical students, it's so easy to just look at the patient and watch them walk and listen to them talk and watch them get out of a chair before you even have to touch the patient. And then doing that, thorough neurologic exam to get your assessment of strength and sensation and things like that. But I find that, even before you touch the patient, you can get so much information.
Yeah. Do you guys find any disadvantages using the surveys?
Yeah, I think the surveys can be cumbersome for some. I think that the questions may not even pertain, particularly with spine. Sometimes if it's like a hip arthritis, it's hip pain and it correlates. But a lot of times with spine problems, it can be more of a functional problem, or it's leg pain, even though they're asking about back pain. So it's hard for patients to sometimes tease out the questions. And sometimes they don't really have pain, but they have disability. So, trying to tease that stuff out can be a limitation. And then, depending on who's filling out the survey, who's educating them on what we're trying to do, how much time they have to do it. There's so many limitations to that information.
Yeah, and you agree to echo you. It's depending what time of the day these patients are collecting the patients. Obviously, 5 out of 10 for one patient is not 5 out of 10 for different patients. Yeah. Anything you see, Mattei?
No, I would say, don't get me wrong in terms of the importance of patient-reported outcome measures. It's the workhorse of research in spine surgery. And we can look at radiographic outcomes, but I don't think it should be an excuse for the physician to do a 5-minute consult and rely on 10 pages of ODI, VAS, SF36, when basically you should spend some more time asking the patient, I see you walking, I see you have maybe a myelopathic gait, but how do the activities of the daily living, how do you go about them?
Right.
How does this affect your sexual life? How does this affect, do you exercise? Are you able to, do you need help for showering? I think all those things, you may even have in the surveys, but there's nothing better than having the patient feedback, and sometimes the patient is with the wife or husband, and that, at least for that individualized care for that patient, it gives a very good impression, even that is very important for you later. You operate on that patient and you remember that very well. How can you objectively document that to the point that that's useful for research is a different question. But if you're focused on the individualized care of that specific patient, I think that should be the goal, and it's not that hard. But it takes effort and it takes time.
Yeah, and I think the timing of the PROMs is important. So the post-operative data collection, if you do it 4 weeks post-op, you may not get great scores because patients are still recovering, they have pain. And then, you really want to look at the farther 6-month, 12-month data to really see the improvement. And sometimes there's some recall bias too, like patients may not recall, before and after what their situation was. So there are limitations, but I agree, there's so much good information there.
Yeah, so as long as you're aware of limitation and you know how to use it, and this can be a great tool.
Yes.
Now, if you like to collect some more objective outcomes, I mean, you probably guys know it, you can refer your patients to a motion lab for a gait analysis. Right? In gait analysis, you can get more objective outcome, how the patient is walking. I mean, the step length, step time, walking speeds, how much they swing. Some labs has EMG. You can get some neuromuscular activity while the patient is functioning. In our labs in U of R, we're actually doing a set of ergonomic testing. We actually ask the patients to walk, to stand, to move from sit to stand, lifting, and other activities. And then we can provide, in addition to the surveys, more objective outcomes of what is the patient is actually able to do. Mm-hmm. Right? Any experience with referring patients to a motion lab or working with data out of a motion lab?
We used to send a lot of our patients when I was doing my fellowship at the Ohio State University. We had a biomechanics lab there, and we had some motion analysis protocols. But one of the things, especially for those who are not in academic centers and that can be very valuable, especially when patients request you to go on things that you may not be used to. And they say, hey, can you discuss this with my lawyer? Or I am 100% disabled. I mean, that's the type of thing that for me, a functional capacity evaluation is the ideal tool. And I bet even in small cities, you can find a good physical therapy that is going to spend an hour or so with the patient and evaluate what are the limitations in terms of weightlifting, bending, and during the whole environment, and provide the categorical how many hours they tolerate doing this activity or that. So I think that the lab it gives us a lot of data, a lot of information, but I'm just afraid that may be limited to just a few academic centers and especially doing some research protocols. But there are other ways that people can explore these objective measures through simple functional capacity evaluation, which is available.
Yeah, and just to echo you, not everybody have access to a motion lab. Right. On top of the one have access, this service is very expensive, and not all insurance company actually paying for this service. I mean, we see insurance company paying for children with CP, but for spine patients, we keep getting denied for those services. On top of that, don't forget, it's a single measurement point. So again, it depends like the surveys. When do you measure them? In the morning, in the afternoon? How often after surgery? What about you, Jessica? You have an experience with the motion lab?
Yeah, I mean, I think that it's such a great tool to have. And if you're in a big city like Boston and you have medical centers around who have these amazing labs, or Rochester or, Ohio State, that's great. But the limitation is getting the patients there, having the availability and the access, paying for the tool. So I think a ton of really good information can come out of those labs. But, I think you kind of look at it just in a snapshot.
Yeah. And this is what leads us to our next topic, which how we can actually measure patients' disability and functional without sending them to a motion lab. So a new hot word we got right now is wearables devices, right? And we see more and more of this in orthopedic subspecialties. I mean, I know hip surgeons, foot and ankle surgeons using a lot of wearables to assess disability with the patients. The wearables is actually collecting a passive information for your patients. The patient doesn't have to do a lot of things. And we talk about wearables, we can refer to a Fitbit, Apple Watch. We're developing in U of R like a smart patch we're putting on the patient's neck. It can actually be your cell phone considered as a wearables. And the big advantage is they can collect data for multiple days. Unlike a motion lab, you come for a test for like 20 minutes or an hour, basically. Over there, you can collect data for three days. What are your thoughts about using wearables to assess disability for spine?
I mean, I think it's a brilliant idea. I think it's so great to be able to get data continuously for patients and what they're doing day to day over a period of time. I think that can give us so much information. I think especially with myelopathy, we always counsel patients and say, the goal of your decompression is to, prevent you from getting worse. Hopefully you'll get some improvement, but there's a lot of vagueness with counseling patients about what their outcomes might be. And I think being able to really gather more data on, objectively with what they're doing pre-op and post-op, depending on their severity scores beforehand, et cetera, I think would be really interesting to look at. I think it really depends on the patient compliance, which is a piece of that as well. But
Yeah. So patient's compliance is very important, right? The patients actually have to go and charge the Fitbit or the watch. They have to make sure they're using it, and if the apps usually come associated with it, to make sure the apps is open on the phone. So it does require a lot of compliance for patients. What about you?
I definitely think that is a game-changing technology, because the problem that we see sometimes is that, yes, you can do, like we discussed, you can do a very careful analysis of the patient, which is somewhat subjective, but is based on your feeling of how the patient is doing. You're asking the question. It's very hard to translate that to objective data into the research. On the other hand, you have the motion lab, or even some of the patient-reported outcomes. They're very objective. You miss that subjective part of the patient, or they may not fill those questionnaires very well. So we definitely need something that is translatable to the clinical practice, that people can use, that you can incorporate in your daily practice, but at the same time that provides objective data regarding improvement. And I do a lot of spinal stimulation implants, and it's so hard sometimes to rely just on patient-reported outcomes, especially in the elder population. Sometimes they don't even remember how they did during the trial. And sometimes the lead from pain management ended up moving down, and you want to know, but how was the improvement during the first day or the second day? Was the ideal placement around T9-T10 or T8-T9? Because I see both positions, and the rep is there, but they are in some way biased in some sense. So you have to take with a grain of salt when they document whatever percentage. The family, unless they keep a careful journal about that, you don't know. But if you have a wearable, or even if you have a patient that was carrying his iPhone, and you can document that Monday or Tuesday when you're at certain region, they had twice the amount of activity and the distance that they walk from the Friday when the system was turned off or removed. I think that gives very valuable data even to justify your intervention.
Yeah, so as long as you're aware of the advantage and disadvantage of the wearables, I mean, it can be a great tool to assess patients' disability. Don't forget, using a wearables is not exactly like a motion lab. It's like a mini version of a motion lab, but you can still assess, patients' walking speed, how much they actually flexion and extending during the day. Think about this data like a few days after surgery, how valuable this data can be. On top of that, don't forget the patients feel more connected when you put the wearables in the patients. They feel like you're in the wearables all the time, and they try to satisfy you. And by saying that, this can be a great opportunity to raise some red flags if patients are doing too much or doing too less. So instead of like guessing or just rely on the prompts by itself, I mean, you can just get the output from the wearables and then have your PA or the nurse calling the patient and say, okay, listen, you have to slow down, or you need to do more stuff, basically.
And one interesting application that I see for wearables is the inpatient setting. So it's much easier to have compliance with that. And we had a lot of discussion in some meetings about early discharge to rehab and the cost effectiveness of a longer hospital stay. And there's the whole debate. And we're basically relying on the input from physical therapy and occupational therapy. But how are they deciding that? I mean, they're evaluating the patient the same way we evaluated the office. So if they have some data that say, yes, the first day, that's how the patient was doing, but now the patient walked twice today. And yes, he still has a walker, but no, it's a huge improvement. Now, I think today is a good day for him to go to a rehab and take into account that, yes, he lives by himself or he lives upstairs, all the other variables, but at least they have some objective data from the wearables that can substantiate their decision, which is important, right, in terms of insurance approval of one more day in the hospital.
Yeah.
And I think to add on to that point, at Mass General Brigham, in our system, we're starting to do the home hospital. So trying to get patients out of the hospital and having services at home, sending nurses, physical therapists, et cetera. So we can have less patients in the hospital and more care, obviously as a cost savings measure. But how great would it be to be able to have these objective measures when they're going home sooner than, we're used to try to start to collect data and see how safe this process is and how effective it is. So I think, the patient engagement piece is huge. And certainly the personalities of the patients, like in my area in Boston, like patients are very engaged and they're very health conscious and educated, and they want to have this data and follow up constantly. So, I think geographically it can affect how patients do with it. But I think if the surgeon and the patient are, get the surgeon's educating the patient as to why and how it's important and things like that, I think it's a great way to engage patients in their own care.
Yeah, I absolutely agree with both of you on the benefits. One thing I want to follow up about your comments about patients' compliances. We also need to remember that wearables today is still a luxury item. I mean, those wearables cost $100, $200, $300, and not all patients can afford it. So one thing I know we're trying to work on is to reduce the cost of wearables, make it more accessible and feasible for most of the patients. Second thing to think about, FDA approval for these wearables. Because now we're just using wearables mainly for fitness purposes and kind of track how much the patient is moving. At some point, we would like to connect those wearables to the patient's medical charts. And then we may have a risk for data breaching and other, cyber attack, as we know. And the last thing I want to mention is think about how quick the wearables going to advance. Like think about your phone, how your phone looked like 7 years ago, right? And we know FDA approval process take about 6 to 7 years. So by the time you approve one wearables, you already have like 6 new versions coming after that. There's just a couple of things we have to be aware of.
And I see that this coming into the clinical practice, hopefully in the next 5 or 10 years. And one interesting discussion, you mentioned about the data breach, but I've seen some of the graphs of the amount of information that you're able to get on that. Is the discussion, I mean, what are the standards to properly informing the patient about what you're doing? It's very easy to say, hey, can you wear this? And this is going to see how much you're moving. But you're collecting such a wealth of data that to really be an informed consent in the legal sense, the patient has to understand in terms of what are the material implications. And when you think about patients, I mean, there may be some concerns. I mean, we have several workers' comp patients or patients that are involved in litigation. And especially if you're uploading that to their charts, I can see how patients may be somewhat reluctant in using that, even though it may help with their clinical management, for the fear of having something properly documented when for themselves in some way, and that's the way how humans behave, they're telling a narrative. And that's one of the challenges about PROM. There are a lot of literature showing the patients with ongoing litigation, they have worse patient-reported outcome measures. And I don't think the surgeons are having a worse outcome. And I don't think the patients are trying to deceive us sometimes, but they have the narrative that I had the accident, and after the accident, that's when the pain started and I got worse. So I think that's definitely something that we need to take into account whenever we're ready to implement that. I mean, what are the measures or how can we implement that so that we know the patient is being properly informed and consenting to have the wealth of data collected and stored in whatever way we're doing that.
Yeah, I agree with that.
Yeah. So in summary, we spoke about 3 different ways to assess disability and function of patients: surveys, right, motion labs, and wearables. Each of them has pros and cons. So as long as you're aware as a clinician, what are the pros and cons? I mean, I recommend to use all the 3 as possible and take from each the benefit of it.
Yeah. Thank you.
Thank you very much.